Loretta Dillingham, good morning from Brisbane, Australia. See you back here in 57 minutes. Add to broadcast. Very interesting. Glad to hear from you. So, what I'm going to talk about tonight, a couple of events and a case. So, you may remember I do some work with a company called K Health. It's applying artificial intelligence to help doctors. Hello, Mr. Tully. It's applying artificial intelligence to help doctors make a better diagnosis. You know, since there's so few objective ways to look at a diagnosis and see, did I get that right? There have been studies on it, and the studies aren't pretty. One of the studies, for example, I saw where they gave 2 levels of cases to doctors. And those 2 levels were what they considered moderate and then difficult. The doctors got the moderate cases right 60% of the time, and the difficult cases 10% of the time. That's not good at all. But they also asked the doctors, what percent of the time do you thought you got it right? And they all answered about 80% of the time. So, every doc thinks he's great, or most of them do. But we're not nearly as good as we think we are. And that's a problem. So adding something like artificial intelligence is a great way to help with docs. We had one of the guys that developed some of these on the board at MDLIVE, and we've got for the first time, again, artificial intelligence instead of just rules-based engines. Yesterday, I was meeting with one of the local states. Their governor had asked that we meet with their board for Medicaid. So we were meeting with them for that. Now, that's just a side story. Here's the case for this for you guys. So I got out, and Michelle calls me, and she says, well, and she gave me the name of a patient. She said, yep, well, he wants to get a refund. And I said, okay, that's fine. But could you tell me what happened? And she said, yeah. He went to a local doc. It was a functional medicine doc, and he said he finally gave in, and he decided to go ahead and take a statin. It was Crestor, 10 milligrams. And I said, well, again, it's not the financial issue. Tell him that's fine, but he probably ought to just talk with me for about 15 minutes. So we talked last night, and then we talked again today. And sure enough, so I'm going to share with you, obviously I can't share his name, don't want to. And you really can't see these numbers. But here's what we saw on his glucose numbers for the past couple of years. This is fasting glucose, don't have a hemoglobin A1C, no OGTT, none of that. 106, 94, 93, 105, 125. He had a fasting blood glucose of 125 in March of 2016. And his docs have never mentioned blood sugar issues to him at all. So why were they putting him on Crestor? Because he had a positive calcium score. So they said, you know what? I've been telling you need to go on statins for a long time. And here we'll just go on a low dose of 10 milligrams a day. Well, 10 milligrams a day of Crestor is not a low dose either. And so that's just not good. And so I went over, it took me just a couple of minutes to go into his chart, see these things, and say, yeah, again, this is a health issue. If you want to go on a mid to high dose statin and think everything's okay, then that's your choice. But here we've had clear evidence of not only just insulin resistance, which is the more common cause of this problem, but full-blown diabetes. You meet one of the diagnostic criteria for full-blown diabetes. Your doc has never mentioned it to you, and you think you can just rely on that doc to take care of you put you on a moderate to high dose statin, and you're good. And by the way, yep, you can keep eating your oatmeal every day because that's not a problem. So it was a good news, happy ending. He, after a few minutes of that kind of conversation, he said, "Hey, Bart Robinson, glad to see you as well. Thanks. I'm finally starting to calm down. I have to tell you, I've felt like a cat on a hot tin roof. Richard set me up with this software, which was really easy to get into, but once you start becoming a broadcaster, which is what this is, it's like, it can get very dicey. Last 2 weeks, I just blew it up entirely, so I keep getting very much afraid that I'm afraid to go back in the water. Anyway, back to our case for today. So he said, Doc, when I was signing up, I thought maybe I should come to the Louisville event. And he said, given just a few minutes with you on the phone, I'm realizing I can't depend on my doc to do the best for me in terms of prevention. I mean, doc, and and I thought this doc was beyond the standard. He's a functional medicine doc and a functional cardiology doc. And I said, well, I'm glad you're starting to see the light there, starting to see what's going on. He said, you know what, I'm going to go back to plan A, and I'd like to come to the Louisville event. But my problem is I would like to be seen a little bit earlier. I mean, the Louisville event's not till November 8th. And it brought up a good point. We had another patient just last week where the same situation came up, and it was like, I'd like to go to the Louisville event because I'd like to do 2 days of this intense learning. But I don't want to wait 2 or 3 months for that to happen. So what we're doing until September 1 is like a sale. Basically what you get is you get some extra evaluation. And that's what we're doing for him. That's what we did for that patient last week. And just to clarify for you what this, quote, summer sale is you get your extra visit. So you go ahead, get your labs now. I see you. And then you attend the Louisville event, the boot camp, for 2 days. And the labs include the inflammation panel, the OGTT, the insulin survey, cholesterol panel, fractionation, ApoA1, ApoB, metabolic profile, CBC. We're going to do something new this time. We've given out a couple of Freestyle Libre buttons, the continuous glucose monitoring. We're going to give them to everybody this time. Obviously, you get the CIMT. And depending on where you get it, most places it's $150 to $350 dollar value there. So you get one visit. For those that sign up this month, because it's so far ahead, you'll get some lagniappe. If anybody's from New Orleans and they recognize that term, lagniappe, a little extra, like a baker's dozen. So you'll go ahead and see me after you get your labs done. Then you go to the event, 2 days intensive. And again, I'm sorry that you have to learn stuff like this to get good preventive care, but that was the whole point of the example today. He's not getting good preventive care. So you got to take responsibility for your own health. So then you get the one visit with me before the event. You get the 2-day boot camp with a whole bunch of other people, many people of whom have already graduated, been through years of this, and come back. So one of the things you find out is that you listen to others ask questions that you would never have known to ask me. So instead of, again, 1 hour with me, you get like 16 hours, but you get it with other people who are also asking the same, concerned about similar issues, but they've been learning this for 2 years. So a whole different experience. Where you say, no, I'd like to see you individually, you do. And again, if you sign up during this month, August, summer sale, you get to see me. You and I will do a one-on-one before the event, and then we'll do a one-on-one after the event. So, just wanted to go through that, explain that a little bit, and I also wanted to update you on the CIMT Access Tour. Todd Eldridge and I just spent about an hour on the phone today, and one of the things we're looking to do, just for those of you who are going to be in LA, I think it's like September 26, 28. I'm not sure. You can go to cardiorisk.us forward. Send them. You'll fill out your email. They'll let you know. I mean, they'll know that you're interested, and then they'll send you an email to let you know when David's going to be there. So we're going to have basically David's going to come out to do the CIMT and join the CIMT tech. He won't do the CIMT. He's not qualified to do it, but he's going to be doing a presentation. Then the CIMT tech will be doing the CIMTs. Todd, David Wright, and I are planning to come out after that to have more of that kind of boot camp event there. So there you go. Just a couple of things in terms of what we're developing for the next few months. Okay, Wendy Benjamin. Wow, missed this. Well, you didn't miss it tonight, because here we go. Uriel Wong from Hawaii, I remember. Spider person there. Howard Seth, hello from Santa Cruz. Oops, cod liver oil burp. Well, you get plenty of vitamin D with that, don't you? Booster C here in Atlanta. Mr. Tully, hi Dr. Brewer. Larry Deutschman. AI is currently good in the movies. I'm taking 10 milligrams atorvastatin and my glucose has risen as well. He is concerned about my A1C, yet I have to get running again. Where is your event? It's in Louisville, 8th and 9th. Louisville, the November 8th and 9th. You can look on our website and it will pop up. Now, unless we have other questions, which I'll be happy to respond to, I'll also share with you another discussion I had with a patient today. It was one of those patients that had seen Caldwell Esselstyn, had actually been out to Esselstyn's ranch, was a big fan of Esselstyn's, and had said, I mean, we get into that whole debate, and I'm going to start it again tonight, just for entertainment's sake, but also for education's sake. That whole debate about plant-based diets versus low carb and the oils issue, fats and oils issue. So this patient said, he mentioned the problem, and I said, I get a lot of people, just a couple of weeks ago, a lot of people started asking about Esselstyn. And here's the thing, there is no doubt in my mind that the guys doing the plant-based diets have saved a lot of lives. Because it depends on your where you're coming from and what you're looking at. There's tons of research which shows that if you go from the standard American diet to a plant-based diet, you're going to improve your health. There's no question about that. And yes, Pritikin and several others have shown actual objective evidence. But this was one of those patients that had lost a lot of weight on a plant-based diet, was seeing Esselstyn. Esselstyn was still cranking down further and further. Get those oils out of your diet. And really never took a look to see if the guy was insulin resistant. He had an event, and obviously after losing many, many pounds, a third of his body weight, and then he said, I've done all this work and I've lost all this weight, and then I had a heart attack. He started watching some other channels, and this one, he saw one of my videos on triglyceride over HDL. He took a look, and his triglyceride over HDL was 5. Then he realized that he was loading up on carbs so much because he was decreasing the fat content of his diet that was creating more and more risk on the insulin resistance side. So, I think at the end of the day, plant-based diets are great. I was on a plant-based diet for 40 years, 30 years. But I like most of the rest of us, I became insulin resistant as well. So here's the thing. Yeah, plant-based diets can work. You have to obviously do a couple of supplementations, I think it's like B12. But you have to watch your carbs. If you don't, you can get into big trouble. And you don't have to be heavy to have a carb problem. The patient that we talked about today that had that fit the diet, the definition of full-blown diabetes, he was thin, I'm thin, I've got a BMI of 20, 21, and I still, I eat I'll try a Proline diet, and those soups in the Proline diet will take me up to 180. So you just got to be careful about carbs. It's not just plant versus animal based alone. Amazon Werner, Robbins, Georgia. How you doing? Mr. Y. Tully, question. I would love to get a continuous blood sugar monitor, but I don't have a doctor. Does your group give prescriptions without paying big bucks? Well, our group does give big prescriptions, and I don't know what you mean by big bucks. We've done a trial on it, and here's what we do. Actually, it ends up being a great value because we'll do an inflammation panel and an OGTT and some of the basics, so you begin to learn what your risks are. We don't do a full-blown $1,000 exam. We do you end up getting most of that, but we only charge like $500. Now you may say $500 is too much for that. If you do, I understand completely. Okay, Mr. Tully, for all the tests you provide. Oh, now that it's a good point. The way we're set up, we're not paying for the tests. We can do that, and for those of you who do want to get some testing, I do suggest you ask Michelle about what's called cash labs. It's just another one of those nasty things about buyer beware in healthcare. So most patients will say, or until they become familiar with this problem, will say, you know what, I'm going to see if my insurance will pay for it, so let's not worry about it. They go in, the insurance pays for about half of the labs, but that turns out to be 1/10 of the price because the labs realize if the doctor hasn't already paid for it, if the insurance hasn't already paid for it, now they've got you. And you've got no way around it because you've already gotten the labs. Guess what my labs were when I did a self-pay that way? The first time I did this about 5-6 years ago as a patient. I wanted to go through the patient experience. I don't see any guesses, but guess, if somebody would guess, I would appreciate it. While we do, I'll wait till somebody guesses before I tell you how much I had to pay for my labs. But first we'll go into another question. Ken Patu, on this topic, what precisely causes CV inflammation? Is it as simple as blood glucose? The plant-based crowd say meat causes inflammation. Hard to believe. So again, and Mona Dimitri, hi, I love to listen to you. Booster C said $3,500. Close, but no cigar. $4,500 is what they charged me, and then I just started. At first, I paid most of that, and then I started saying, you know what? Come get me. I'm going to argue with you because this is silly. They kept sending more and more bills. So that's the problem. So now we'll go back to the question about inflammation in just a minute. But on the let me just finish out the cash labs thing. So typically these labs will cost anywhere from $1,000 to $2,500. I've authorized Michelle to do what we call a cash labs thing, and that's where we say, okay, we will negotiate up front with the labs for you. And I don't remember what it is. I think it's like $1,200-$1,500. Then you don't have the risk of going to the $2,000, $2,500, $3,000, that sort of thing. So again, give Michelle a call. You can see her number on the website, and she can give you a lot more details. I will tell you this, I get into significant trouble and I butcher things up every time I start getting into numbers. The numbers I've given you tonight, I think, are mostly accurate, but again, that's why we are where we are. Now, somebody asked about inflammation. What causes inflammation? I'm going to interpret your question as saying, what causes inflammation? Is it meat or is it carbohydrates? And let me tell you why. Back in the 50s, we all decided that it was meat and fat. If you go into an artery and you take a scalpel and open it and then look at it under the microscope and analyze it biochemically, almost all of that plaque is going to come out to look like LDL, small dense LDL particles. Bad cholesterol. That's why they call it bad cholesterol. Well, the reality is, cholesterol does matter, but not nearly so much as we thought. What's going on is this. If your blood sugar goes way up, or if your insulin values go way up, trying to control your blood sugar, it burns the endothelium, the intima layer, the glycocalyx. I know a lot of people on this that watch this channel know those three terms. But the bottom line is it burns the lining of the artery wall. It's not until and unless that lining gets burned that LDL starts slipping through the lining and it gets lodged in the artery wall itself. That LDL is the cholesterol that we've been seeing for 100 years or more. And that's why everybody came to the conclusion it's LDL in the artery wall, so it's got to be LDL that we're eating. So therefore it's got to be meat. What they didn't realize was, no, that stuff doesn't leak into the artery wall unless the lining has been damaged. And it's high blood sugar, over 140, and staying at 140, 180 for hours every day, that does the damage to the glycocalyx / intima / endothelium. So, Ken Patu, I hope that answered your question. Mona Dimitri, hi, love to listen to you, thanks. So Booster C, yep, you guessed it was 3.5 thousand. It wasn't. It was 4.5 thousand. Now, and again, I gave you some background on that. John Panazzo guessed 5,000. Teresa Cesario, 2,500. Loretta Dillingham, 4,000. And again, I think, don't hold me on this, but I think that our cash lab for the whole panel, not just like a mini panel that we would do for CGM, I think for the whole panel is something like $1,500. That way you go in, you're going to get all of them, and you're not going to have to pay anything else. Which brings me back around to connect a dot. You know, if you go to the Louisville event, all of those labs are included in the tuition for that Louisville event as well. Paulette Teal, after breast cancer, had heart exams by 3 different cardiologists. They said the heart was fine, just had CAC of 1167. Well, that's sort of an oxymoron. The heart's fine, you got a positive CAC. Yet another cardiologist appointment on Tuesday, have lost 12 pounds in 2 weeks on keto. Blood pressure excellent on keto. And the reality is, yes, your heart function can be fine. You've obviously got some plaque in your arteries. If you didn't have plaque in your arteries, you wouldn't have a positive coronary artery calcium score. So, brings up a good point. So, how do we measure plaque? What's by far the most common way of measuring plaque in this country today? You go get a stress test. How much sense does that make? What does the stress test tell you? A stress test will be positive if you have occlusion of over 50% of the coronary arteries. Guess what portion of heart attacks occur in people that have occlusion over 50% versus less than 50%? That's another pop quiz. Oh, I won't wait for answers. It's 68%. 68% of heart attacks occur in people that have less than 50% occlusion of the, pardon me, I was hitting that. I realized I was probably banging your ears out. 68% of heart attacks occur in people that have had less than 50% occlusion of their coronary arteries, which makes the point, why on earth are we using stress test as our screening test for plaque? There are a couple of good ones, and of course they're not used very often. One of them is the coronary artery calcium scan. I am so glad, Paulette, that you at least got one of those. And number two, the CIMT. And the CIMT is, it suffers from the needing to get a good, reliable technique. Most CIMTs or us don't have a good, reliable technique. In fact, about half of the patients that come to me and say they already have their CIMT went to a local radiology group, and it wasn't even a CIMT. It was just a Doppler study of the carotid artery. So that's the reason that that we don't have good screening for arterial plaque in this country. The tests that we're used to using, the things like stress tests, nuclear scans, things like that, way too expensive, way too just bad. They don't really tell us that much. And the tests that are better, just people have not seen them, have not used them. Not parts of the standards of medicine yet, so not getting done. Paulette Teal, doesn't Medicare and supplement cover labs? Yes, they do. They'll cover things like the microalbumin creatinine ratio. They'll cover the CBC. They'll cover the metabolic panel. And together, all of those are worth about $30 to $50. They may cover part of the oral glucose tolerance test. They don't cover all of the extra insulin. They don't cover the extra insulins associated with it, and they don't cover the inflammation panel at all. So, again, you get about a third of it paid by Medicare, and like I said before, you don't want to be a patient standing there alone with you in the lab because they keep coming at you and they keep charging ridiculous amounts. It's like hospitals do with ER care. If somebody comes in as a self-pay, they charge them 10 times what somebody comes in that has a pre-negotiated insurance rate. Same thing with pharmacy. It's, again, healthcare is it's a very bad place. Buyers beware in terms of costs and managing that. Richard Lund, does high protein intake increase inflammation due to getting rid of nitrogens? It depends on your kidney function. If you have good kidney function, the extra protein that's so common in the American diet is not really that problematic. It's not that good for you, but it's really bad for you if you already have some kidney damage, and that's where we get into problems. The nitrogen itself really does not cause significant inflammation. The vast majority of the inflammation is caused by, again, burning that glycocalyx with insulin and especially high blood sugars. Loretta Dillingham, that makes a stress test laughable, doesn't it? And here's another pop quiz question for tonight. How many stress tests are done in the U.S. every year? Ben F. M.D. I agree that hyperglycemia contributes to endothelial damage and subsequent plaque formation. But from what I have read, it is hyperinsulinemia that is the main culprit. Of course, they correlate. Yeah, Ben, I'm guessing that the Ben F., I guess the MD means you're probably a doc. And you're right. There have been studies that make it very clear insulin itself is inflammogenic. I mean, it causes inflammation. But if you think about the studies, how are you going to separate out on a month-by-month, year-by-year basis separate out high blood sugar and insulin. In fact, you actually can, and it's not that uncommon. It's in somebody that's got full-blown type 1 diabetes who's just not making insulin. And as you know, just go through the logic. Those guys really have problems laying down plaque really fast. So I think part of that will help you, help logically help you understand that, yeah, blood sugar alone does it too. The question is it ever just insulin or ever just blood sugar? Well, in full-blown brittle diabetics, yes, it's just blood sugar. But here's maybe the bigger question on a practical basis. In what way and why and how does it really matter which of the two it is? Because it's a chicken or the egg question. Booster C, I'm 65 years old. Congratulations, Booster C. Started ketogenic diet in the second week of February. Started it because of inflammation and bursitis in the hip. Inflammation went away within 3 weeks. To date, I've lost 70 pounds and blood pressure down, such as off lisinopril. You have saved your life, Booster C. And, with a 70-pound weight loss, it's impossible to estimate, but that could be 1, 2, 3 decades of non-disabled life. The actuaries are predicting that a relatively healthy 60-year-old now is going to live into the 90s. So if you've lost 70 pounds, if you're getting down to a BMI of in the low 20s, congratulations. Not empty. Any suggestions for anti-inflammation? 2.5 grams Crestor 2 times per week was too much for my genetic profile. Well, that's actually not empty. That's a great question. I've had people on 2.5 milligrams once a week. And that may sound really out there, but there's actual there are studies that have been done using low dose once a week Crestor. Now here's another question that I would have for, was it almost empty? I don't see it now. This question about 2.5 Crestor. Did you ever try Livalo, pitavastatin? I'm actually switching. I went to the Canada Online Pharmacies, and am going to be trying my own version of Livalo, generic pitavastatin. I did a video on it to give you a little bit of background on it, but it's like $75 for 100 pills. I have a ton of patients who've been doing this for years now, and several of them were on it not because of the fact that, here are a couple of major advantages with Livalo and pitavastatin over all of them. All of them cause some degree of pushing you down that diabetes highway. Even Crestor. Crestor 5 milligrams per day or less, just a minimal effect, but obviously the mid and high range intensive doses clearly push you down that diabetic highway. Pitavastatin does the opposite. It actually helps. It pulls you back up the diabetic highway. So that is a breakthrough medication. I didn't use it for the first year that it came out, and here's why. And it was partially because of the expense, but here was the other thing. It had not been documented that pitavastatin had the impact on the inflammation. And just to remind you, the vast majority of the cases, I don't really recommend statins for LDL. I recommend statins for inflammation, arterial inflammation. Well, the data has come out, the research has been done, and pitavastatin does help with inflammation. So it's like, if it weren't for that cost thing, pitavastatin would be a major answer. Not empty, the other reason I bring that up is several of my patients that are on pitavastatin are on it because they can't tolerate anything else, including Crestor. So it gets me back to, have you tried pitavastatin? Craig Larson, hi, and thanks for all you do. Well, Craig, thank you for the recognition. I appreciate it. And thanks for your interest. And please boost this, send this to people, put it on, put the videos on things like Instagram, Facebook. Because when you do that, if somebody actually comes back over from one of your references to Facebook or Instagram or one of those, and they come back to YouTube and they watch one of these videos, what happens is the algorithm within YouTube reads that and says, hey, you know what? This stuff must be interesting for some reason or another. Once it starts seeing those kind of boosts, it'll do its own internal boosts. And obviously the YouTube algorithm can boost this information more than any of us. It's just waiting for us to tell it what's worthwhile, what's helpful, what could be helpful to people out there. Janet Kemp, way to go, Booster C. I agree. 70 pounds, life-changing event. Walter Ski, and I'm guessing, I don't know if that's water ski or snow skiing. But Walter Ski says, I recently heard that CIMT, sort of sideways, it's CIMT, not CMIT, 2 may be implied, only picks up hard plaque, but it is the soft plaque that causes a heart attack or stroke. Excellent point, Walter Ski, and I'm going to respond to that in just a minute. So they were dismissing CAC testing. Can you comment? I would love to comment, and thank you so much for bringing it up. What does the first C stand for in CACS? Coronary. So I screwed up. So what's the second C stand for? Calcium. You're exactly right. The coronary calcium score only tells you about calcium. And the calcium is only found in a hardened, stable plaque. The kind of plaque that causes heart attack and stroke is soft. I wish I had a picture. I'd show it to you. Well, I've got one of these that I'm doodling around with. It's a model of an artery, but I don't think it really doesn't. It doesn't differentiate between hard and soft plaque. Calcified plaque's not going to cause a heart attack. Soft plaque does. But here's the major twist, Walter Ski. You said CIMT, 2 may be implied. No, it doesn't. CIMT tells you. CIMT is an ultrasound. So coronary calcium is a type of computerized tomography, CAT scan. So it's got radiation. Now, and so people say, oh, don't get a calcium score more than once or twice. That's silly, because we're talking about a 1 in 1,000 probability of cancers associated with that. And that sounds like a lot, but what we're talking, once you get plaque, significant plaque that doesn't even impact your flow, you all of a sudden went from less than 5% probability of a heart attack over the next 10 years to over 40%. So that risk, and knowing about that risk, dwarfs this issue of radiation with coronary artery calcium scan. CIMT is an ultrasound technology, so there is no radiation. We can do those on infants, and tens of thousands have been done on infants. That's how we can do your arterial age, because tens of thousands of CIMT have been done on infants, 5-year-olds, 10-year-olds, 15-year-olds, 20-year-olds, etc. And no, it doesn't just look for calcification or hardened plaque. It shows you the soft plaque as well. I'm gonna make a criticism of somebody I admire and feel I'm very impressed with him, Ivor Cummins. I think it's like the King of Fat or some Fat Emperor. I've watched a lot of his stuff. He's very, I like the vast majority of it, and I agree with the vast majority of it. But I don't agree with this piece. He doesn't seem to know the CIMT area very well. The guy that's funding him is that Irish businessman that was first alerted to his cardiac problem by a positive calcium score. They actually did that movie, The Widowmaker, and it's a great movie, and I would love to see tons of people get a calcium score, even though it's not as good as the CIMT. It's much more available, much more common. But the bottom line is, if you work it right, you can get a really good CIMT anywhere in this country. So to say it's not available is sort of not right. Here's the thing. I'll go back to where I was a minute ago. I haven't seen anybody make a guess. I left a question out there about how many are done, how many stress tests are done. I believe it's about 5 million. So what, about 15,000 a day in this country, stress tests, and whole bunch of false positives. And you know what a false positive on a stress test means. Go into the cath lab, stick a needle up through your groin, and even worse, a false negative, which means, oh, I'm great, I'm good, I don't have any risk. So that's what we're doing. I would love to see just 10% fewer stress tests. I'd love to see 90% fewer, but even just 10% fewer stress tests, and that money used for calcium scores and CIMT, it would be huge. So, yes, Nathan Petty, any update on LACIMT? I mentioned before you came on, Nathan, that I don't have clarification or confirmation on the date. It's going to be in September, I think late September. If you sign up with, if you can read this, CardioRisk, let me see if I can move over, cardiorisk.us/forward. Pardon me, I have to move my hand backwards from what I'm seeing on here. I would never make a good weatherman. But if you'll go ahead and register there, they will send you an email to show you exactly when and exactly where. But David Meintz is going to come out. He's going to give a few hours worth of discussion and presentation on risks. I'm going to be setting up my deck. He's going to be using some of that. Todd's going to give him some of his deck. He'll be using some of that, and then he'll be using some of his own information. The key thing is the CIMT will be available there. Yes, you signed up. Thank you, Nathan. Okay, Teresa Cesario. Teresa, whatever. I recognize that picture. You've done several comments on the channel. I appreciate your interest. So, Dr. Brewer, do you know if these traveling screening companies are trustworthy? For example, Lifeline. That's a very good question. Actually, I've had several techs. Barry something or other. I can't remember Barry's last name. He was a tech that came to Todd from Lifeline, and it's a good news, bad news scenario. Lifeline just pumps people through. They've got a great marketing perspective, and I know I get pummeled whenever I bring up the title of the term marketing. The bottom line is people have to hear about stuff. They have to have health behaviors marketed to them to be made aware. Lifeline is a master of doing that. Now, the CIMT that they do is not great quality. You can still, quite often, we get a lot of people that will go to those, see those, bring them to us, and actually, quite often, we can actually look and find some plaque on there. But I wouldn't trust a Lifeline CIMT or ultrasound. In fact, a lot of the screening companies do just like most patients do that come into me, and they just do a Doppler. They don't do the full IMT component. So you really can't tell anything from a lot of them. If they're positive, they're positive, and you know that, okay, I just went to a 40% probability of having an event over the next 10 years, so I need to get serious about this. But if they're negative, they don't really tell you anything. That's the problem. And that false sense of security from getting a false negative can be lethal. Ask the family of Tim Russert and thousands of other Americans. Teresa Cesario, thank you so much. You've helped me so much. Well, Teresa, thank you. I'm glad that we have, and I am glad to see people that will actually take the time. You know, who wants to spend all this time having to learn other people's profession? I'm ashamed for the medical profession that that's the case, but it's the case. It's the reality. So it's very much an issue of the best patient is a well-informed patient, and I really appreciate it when you guys pay attention to this stuff and start learning it, because it doesn't take long to get a lot smarter than your doctor. Richard Morris, you're such a great help, Dr. Brewer. Thank you. Ben F. MD. Okay, we're back to Ben's. Dr. Ben, I'm referring to the patient with normal hemoglobin A1C, but who is insulin resistant and requires high insulin levels. Oh, yeah. Actually, Ben, that is a great point. I've seen 2 patients over the past 2 weeks who had pristine, beautiful OGTT values. 80s on their fasting sugar, less than 120 at half an hour, 1 hour, back down below 100. Yet they were they had plaque. They had significant plaque. And one of them was taking over a level of 100 of insulin to keep that glucose level down below 120. So, for those of you who are not familiar, I'm sure Dr. Ben is. You want your blood sugars to stay below 120, and that's why I get not only the OGTT that you'll read about in books like Beat the Heart Attack Gene, but I also get insulin values to go with it. Because it's not just a question of your blood sugar alone, like Dr. Ben has said a couple of times, and thanks for keeping after that issue, Dr. Ben. It's also insulin. How much insulin is it taking for your body to push out to keep those blood sugar levels down? Because that will cause just as much plaque as blood sugar values that have gone out the roof. And I guess the other point, Dr. Ben, that you probably make by this question is, well, Brewer, that's not that patient. Those 2 patients you saw and just described, by definition, didn't have huge blood sugar problems, but they did have insulin problems, and they did have inflammation, and they did have plaque, and they did have significant risk for heart attack, and it was coming from insulin. So thank you for continuing to dig on that issue. Such a patient's running euglycemic and high insulin. For those of you who don't get too confused about Dr. Ben's doctor speak, U means true, and glycemic means glucose. So the patient is euglycemic, has true glucose values, but they still have high insulin, and that is causing their inflammation and plaque and risk of death, and in many cases, heart attack and dying. Nathan Petty, congratulations, Booster C. Inspirational. It is inspirational. It's incredible. Canal Road Adventures. Soft plaque volume is 5 times the measured calcified plaque by a CAC scan. Well, that's not always the case. You know, if we get somebody calmed down, for example, if somebody had a significant weight problem, let's say Booster C prior to his 70-pound weight loss, and he was continuing to have insulin resistance associated with the increased leptins and adipokines and fat mass, loses that 70 pounds, slows down that inflammatory process, he can get all of his plaque to a point of being hardened. At that point, you don't have 5 times the amount of hardened plaque with soft plaque. But again, that's why we have to watch both, follow both CIMT values and inflammation values and glucose values. Nathan Petty, your note just disappeared, Nathan. Hopefully I'll get to it a little bit later. SP, taking one example of one functional medicine quack screwed up to try to destroy people's trust in just to attract them to your business. This is low. Hey, let me just say something. A lot of people think I'm a functional medicine doc, and in many ways I am. I've been to functional medicine training. So I am not, if you heard that, SP, I am very sorry that you heard that and interpreted it that way. I consider my doc that does cross over into functional medicine. I've had functional medicine training, and this had nothing to do with bad-mouthing a functional medicine doc. For those of you who interpreted it that way, my apologies. And clarification. Loretta Dillingham, yes, but you have to have had the soft plaque in the first place. You're exactly right, Loretta. You don't go straight from nothing to hard, stable plaque. You have to have gone through the inflammatory process and the soft plaque process. John Panazzo, is pitavastatin significantly better than pravastatin? I think it is. Now, John, and for the rest of you also, just to remember, you can get pitavastatin. It's very expensive. I don't know. Well, I'll take that back. On one of the events we did last week or the week before that blew up, somebody actually calculated the dose. So you've got a couple of choices. The cost per dose that these guys were getting, and I got recently from Canada Pharmacy online, was 1/10 of the price of what you would get if you go to a U.S. pharmacy. There's a trade-off, and there's a video that I'm putting out that goes into details. If you're nervous about medications that are made overseas, these are generic medications made in India. So, and you can look them up. There's a lot of criticism about generic medications made overseas, and there's a lot of criticisms about quality for Canadian pharmacies that sell to the U.S. I went into some detail in that on the video. But either way, yes, pitavastatin it's a much better drug. It's just that we had to figure out, number one, did it decrease inflammation, and number two, what's the cost issue? Janet Kemp, so are women who are now routinely prescribed calcium a ticking time bomb if it's going to the arteries rather than the bones? Yeah, I would, if I were a woman, or if a woman in my family were being prescribed calcium, I would do a little research on that, a lot of research, because I think that's a little bit outdated for the most part. Fosamax and some of the other drugs associated with this continue to show positive results, but just taking calcium alone for women is some practice that you should investigate. Canal Road Adventures. If you want to know your arterial age, just look at your birth certificate. Well, see, that's not exactly right, Canal Road. I was 56, poster boy for health. Admittedly, to you guys that are plant-based diet haters, I'd been on a plant-based diet for 30 years. But always kept my BMI in the low 20s and expected to do a victory lap after my first CIMT. And the problem was my arteries were 73-year-old arteries. I go into all the details on that. I've got a couple of videos. If you just Google Ford Brewer YouTube, how to reverse 20 years of plaque, you can go through the whole scenario on that. So no, that's not your arterial age. It's the biological age of your arteries. Loretta Dillon Ham. Actually, the radiation risk is quoted as 1 in 20,000 for CAC, which Ivor Cummins states in engineering terms equals 0. And here's the thing. It's 1 in 1,000. I'm glad you brought that up, and thank you for the clarification. It used to be 1 in 1,000 5 to 10 years ago, and it has improved dramatically since then. And that's only 1 in 1,000 if you are an infant. We're already talking about, for this kind of screening, we're already talking about somebody who's in his or her 50s or 60s. So you've already lived most of your life and lived past most of that risk of radiation. Bottom line, once you get, if you're a baby boomer and you're considering and concerned about plaque, I agree with Ivor 100%. Radiation safety is not a concern for the calcium score. It is if you're going to start screening 5-year-olds and infants, but it's not really for adults. And that's why you can get CIMT for infants. Canal Road Adventure, CIMT not as good as CAC. CIMT doesn't examine the heart arteries. So that makes an assumption, Canal Road, that plaque happens in one place but not the other. Plaque happens because it's a biochemical or systemic problem. They've actually looked at that, and the probability of having plaque in your heart but not in your carotids is less than 2%. So routinely, if I see a patient and I have any reason to suspect plaque, and if they don't have it in their carotid, I'll also ask that we do an ephemeral. That drops it another 1.5%. We're going to pick it up. So yeah, it's a different arterial bed, but all those arteries are suffering from the same levels of glucose. They're getting the same levels of insulin. And as Dr. Ben was saying, look, whether it's insulin or glucose, it's hitting every artery from your femoral to your carotid to your coronary. Okay, Paulette Teal. Women should never add calcium supplement. That's my basic summary as well, Paulette. Naomi Davidson. Husband is 50 years old, just had a CAC of 175. Referred to a cardiologist. What should be his next step in treatment? The first step for any of us should be to go ahead and get an inflammation panel. The second step should be to get an OGTT. And even with the labs that your husband has, I'd go straight. The first place I'd go look at his lipid panel, his cholesterol panel, and look at his triglyceride over, and put that triglyceride number over HDL. You put the triglyceride over HDL, and if it's over 1, we've got some significant risk associated with insulin resistance, which is the major cause of this problem. So I hope that helps. Richard Morris, I have painful heart palpitations, so I have high cortisol levels and type 2 diabetes. Would it point to a stressed liver rather than just diabetes? Well, we're starting to get a lot more recognition of NASH, NAFL, fatty liver disease, non-alcoholic fatty liver disease, NAFL, NASH, non-alcoholic. I'm having a senior moment, but actually, the reality is that you do see a lot more liver stress than people have been aware of. But and cortisol does go along with that, and the same treatments for insulin resistance and type 2 diabetes help for those liver problems. The hour is getting long in the tooth, guys. I greatly appreciate your interest. I'm just going to hit a couple of more questions real quick, and then sign off, so people don't see an hour and a half video and say, I'm not going to take the time to do that. Mr. Whiteley, stress test. I refused the $400 stress test and only did the 150 calcium test. This was based on Dr. Brewer and Fat Emperor YouTube watching. Well, I think you made a good choice. Teresa Cesaria, thank you so much. Helped me. You're a great help. Okay, guys, thank you again for your interest. And again, I know that it's a challenge to have to learn all this stuff to protect yourself from heart attack and stroke. Maybe one day medicine will develop to the point to where you don't have to. Thank you for your interest. Now, there we go.